Tantor Audio presents The Pain Antidote, the proven program to help you stop suffering from chronic pain, avoid addiction to painkillers, and reclaim your life. By Mel Pohl, M.D., and Katherine Ketcham. Narrated by Perkins. Publisher's Note: This audiobook is packaged with bonus material, which has been included on the first audio and MP3 CD. If you downloaded this audiobook in a digital format, please visit Tantor.com and type The Pain Antidote into the search box. Follow the link to the book's page, then click on PDF Extra 1. When prompted, enter the access code SERENITY to access the bonus material. How to use this book. Who is this book for? In short, The Pain Antidote is for anyone with chronic pain. When Kathy and I started to conceptualize this book a few years ago, our compelling intention was to reach out to a broad audience of people suffering with chronic pain. Some of our listeners will be using opioid drugs to relieve their pain. You may take them infrequently. At most, I take 1 or 2 Vicodin a day, exactly as my doctor prescribed for me, and in 5 years I haven't increased the dosage. Is this book for me? Perhaps you are taking high doses of multiple drugs. Your drug use may be causing problems for you, and you may know that you are dependent on the drugs for relieving your pain. I need the drugs to relieve my pain, but am I addicted? How can this book help me? Or perhaps you do not take any opioid drugs at all. Well, I took OxyContin when my doctor prescribed it, but I stopped years ago, yet I still have pain. Why should I listen to this book? We wrote this book for all such listeners, for anyone who lives with chronic pain. We also wrote this book for family members who seek to understand the nature of chronic pain and how to help their loved ones. We wrote this book for physicians and other healthcare professionals as well. Many doctors anticipate poor outcomes for their patients living with chronic pain and for their addicted patients. And yet for most physicians, these patients constitute a large percentage of their practices. Understanding how opioid drugs affect the brain and body helps dismantle many of the myths and misconceptions and clarifies the rationale for treatment methods and setting realistic goals. Listening to the dozens of case histories in the chapters that follow will help doctors and other healthcare practitioners understand the devastating personal cost of chronic pain, as well as the courage and determination required to learn how to live and thrive drug-free. I have treated hundreds of people with chronic pain and watched them transform themselves from drugged, disabled, and depressed to alert, awake, and truly joyful for the first time in years. This is the closest thing to miracle work I've ever done in my 38 years as a physician. I travel and lecture all around the country about this topic, and after being away from the treatment center for 3 or 4 days, I can see the astonishing changes that take place in men and women, some in their teens and others in their 80s, who were once severely debilitated by physical and emotional pain. I'm greeted with smiles, laughter, hugs, and stories detailing their progress, and my heart swells. What will I learn? You will learn that you can live a rich and full life with chronic pain. In these chapters, I share stories about the successes I have witnessed and offer details about the techniques and strategies that have proven most effective for people living with chronic pain. The program set forth is eminently practical and easily adapted to your individual lifestyle. Most important of all, these methods work. They can work miracles if you do the work. Why do I have pain and why won't it go away? What's going on inside me? You may be wondering. These questions are often expressed with a sense of hopelessness and despair. Being well informed about the nature of chronic pain will help you break through your confusion and fear. Thus, Part 1 focuses on the physiology of pain, the powerful role emotions play in chronic pain, and provides clear answers to questions about drug dependence and addiction. In Part 2, you will find the most effective techniques and strategies, all of which you can learn and practice on your own in your own home to help you live and thrive with chronic pain. You will also find information and advice about professional therapies, such as acupuncture and physical therapy, with details about the basic philosophy and techniques to help you understand why these methods work for so many people in chronic pain. The Jumpstart plans detailed in Part 3 are packed full with practical and useful suggestions, and we devote an entire chapter to the connection between food and pain, again, with practical, detailed information and a PDF companion filled with dozens of healthy recipes. If you find yourself in a rut, this information will help you choose between the many options available to you to create week-by-week recovery and meal plans that you can proceed with at your own pace. As you listen to this book, keep in mind that there is just one absolute requirement for this program to work for you: commitment. Throw yourself into this book, make a commitment to work the program set out for you, and have faith that the information and healing strategies you discover will make a difference in your life. Because you can change your life. The antidote to chronic pain is within your reach. With awareness, courage, diligence, hope, faith, joy, compassion, and wonder, a new life full of meaning and purpose awaits you. An important note about discontinuing medications. Throughout this book, we'll talk about life without painkillers, but you must not simply stop your medications. Over time, your body most likely has become accustomed to them, and you may be physically dependent on them. Simply stopping these medications suddenly may be dangerous. You must consult a knowledgeable health care provider or treatment center to supervise withdrawal from habit-forming medications, including opioids, sedatives, hypnotics, and alcohol. 2 more pieces of information for you. We use the term opioid throughout the book because it is a more accurate representation of the terminology for narcotic painkillers than opiate, which is derived from the poppy plant that contains opium. Common opiates include morphine and codeine. An opioid is a substance, molecule, that is synthetic or partly synthetic and not found in nature. The term opioid covers most of the drugs discussed in the book. Second, most of the stories I will tell you are a composite of traits and experiences I've had with hundreds of patients over the past 10 years. Kathy and I do tell actual patient stories with their permission, of course, but have changed other names for the purposes of confidentiality. Your pain is the breaking of the shell that encloses your understanding. Khalil Gibran. In Part 1, you will learn about chronic pain, how and where it is generated in the brain, and why researchers believe it is a disease in and of itself. You will discover how fear, anxiety, anger, guilt, grief, and helplessness intensify chronic pain, and why it is important to distinguish between pain and suffering. We will look at the drugs prescribed for chronic pain and the role these drugs can play in exacerbating and even creating chronic pain. And you will learn the distinction between addiction and dependence, which will answer one of the most oft-asked and fear-filled questions: am I addicted to or just dependent on the drugs I take to relieve my pain? Whether or not you are using opioid medications, the principles and techniques you will find in these chapters will help you live a better life with your pain. 1. All pain is real. Everything you wish you never needed to know about chronic pain. Few experiences in life are more universal than pain, which flows like lava beneath the crust of daily life. Paul Brand and Philip Yancey. Loretta was complaining about her chronic pain. As I shifted in my chair, careful to keep my expression neutral, trying my best to hide my impatience and frustration, I found myself thinking that the words whining and exaggerating certainly applied. I have excruciating pain in my back. Loretta touched her lower back and grimaced, shifting her weight. And in my neck. For perhaps the 3rd time she closed her eyes and bit her lip, as if to underscore the severity of her pain. I found myself not liking her very much. I wanted her to go away. A voice inside me whispered, "So what do you expect me to do about it?" After all, I was an addiction medicine specialist. My work was to help people get off drugs. But Loretta, like so many patients with chronic pain, wanted relief from the pain at any cost, and that meant she wanted more drugs than I was comfortable giving her. She admitted she was addicted to drugs and reluctantly agreed to enter treatment to deal with her addiction because of the pressure from her concerned family members. But she also reiterated in a rising tone of voice that her pain was intolerable without drugs. "You have to give me something to take this awful pain away. I'm begging you," she said. I found myself tightening my jaw and noticed a throbbing ache in my low back. "And my hands," Loretta said, gently rubbing her left thumb and index finger against the knuckles of her right hand, which were red and swollen. "My hands are killing me." "Killing you?" I asked, careful to keep my tone even. Clearly she was in pain, but I knew it wouldn't kill her. What I needed to help her understand was the very real possibility that the drugs might. She was taking massive doses of painkillers, 10 milligrams of Vicodin, up to 10 per day, 30 milligrams Percocet, 6 per day, and, depending on which doctor she saw that week, 80 milligrams of OxyContin, or 60 milligrams of long-acting morphine 3 times per day. Her primary care doctor originally prescribed Vicodin, and when that drug stopped working to relieve her pain, even at higher doses, he referred her to a pain specialist who prescribed Percocet, then added OxyContin, and finally long-acting morphine. She continued to visit her family doctor, who dutifully prescribed 180 10-milligram Vicodin per month, unaware of the magnitude of her opioid habit, or the fact that she continued to get medications from her pain doctor and occasionally visited a local urgent care center or emergency room where she was prescribed even more meds. But at some point, even the morphine stopped working. In fact, she told me that she was in more pain than ever. I pointed to the pain level chart prominently displayed in my office. On a scale of 0 to 10, with 0 representing no pain and 10 being the worst pain imaginable, I asked Loretta, how would you rate your pain? 9, she said, with no hesitation. I consulted her file, flipping through the pages. When you first went to your doctor for pain and started using Vicodin, what was your pain level? Oh, maybe a 4 or 5, she sighed. But it's gotten so much worse. I'm in agony. I can't live without my drugs. I'm miserable with them, but where would I be without them? I'd rather die than live with this pain. I took a deep breath and mentally reviewed the facts of her case. As Loretta's tolerance increased, the drugs stopped working. Even steadily increasing doses of potent pain-killing drugs didn't appear to touch her pain. In fact, her pain was worse than ever. From everything she was saying, it became clear that the drugs were adding to her misery on many levels, rather than subtracting from it. I had seen this before in many other patients. At these dosage levels, overdose was a real possibility, and in the meantime the drugs were gradually robbing her of all meaning in her life. She could no longer work as a grocery store cashier. Her marriage was in serious trouble. Her 3 adult children were so frustrated after years of listening to her complaints that they rarely called or visited, and her friends had abandoned her. She couldn't drive and was dependent on her husband for just about everything. She often spent the entire day in bed. Even getting up to go to the bathroom was such a painful ordeal that her husband purchased a bedside commode. At 48 years old, she was essentially an invalid. In the month before she voluntarily came to treatment, she had seriously contemplated suicide. "Sometimes I empty the bottle of pills into my hand and think about taking them all just to put an end to all our misery," she confessed. "But I'm too big a chicken." Loretta's emotional state deeply concerned me, and I found myself wondering about the connection between the depth of her pain and the intensity of her emotions. As her pain increased, she admitted that she had become increasingly angry and depressed. Was it possible that her emotions were intensifying her pain, functioning as internal megaphones that amplified the sound of her physical pain? My epiphany. And that's when the light bulb came on. Loretta wasn't simply a complainer or a whiner. She wasn't exaggerating. She was in real pain. Real pain that wasn't being helped by the drugs she was taking. In fact, the drugs were making her pain worse. And she was suffering, mentally, emotionally, spiritually as well. Her 9 on the pain scale was an accurate description of her overall experience of pain. At that moment, almost a decade ago, something inside me shifted. Loretta's pain was real. Her suffering was real, and was a substantial part of her overall experience of pain. It was not my job to judge or label her. In fact, it was my job not to judge her. It was my responsibility to help her as best I could, and I wasn't going to be much help if I did what so many other doctors had done and just passed her down the line, treating her addiction, assuring her that I had done all I could do, and referring her right back to her primary care doctor, a specialist, or a pain clinic. Loretta would go full circle and end up right where she was before she came to treatment, except even more frustrated and depressed. I knew from experience that most doctors treat chronic pain with opioid drugs, increasing the dosages in a well-intentioned effort to reduce the pain. Or they refer their chronic pain patients to pain specialists who may prescribe even stronger drugs, adding anxiety meds and sedatives to the painkiller mix. The patient might be scheduled for a series of cortisone injections into the spine, epidurals, or other procedures, such as radiofrequency ablation, whereby the nerves are actually burned with electric current to prevent them from transmitting pain signals. When those procedures don't work, the pain specialist or clinic might refer the patient to a surgeon who, in all likelihood, would suggest surgery because the medications and other techniques weren't successful in relieving the pain. If a surgery was performed and judged a failure because it didn't offer long-lasting pain reduction, the surgeon might suggest more surgery or, just as likely, tell the patient that even though the pain persisted, the surgery was technically a success and therefore there was nothing more that could be done. In essence, the message to the patient would be, I did my job, so if you're still in pain, you're just going to have to live with it, almost implying it's your fault. That's exactly what happened to Loretta after her 4th surgery. A referral to a neurologist or rheumatologist might come next, or a psychiatrist, who might prescribe antidepressants and more anti-anxiety medications, and on it goes. At the time, back in 2006, I had almost 25 years of experience in addiction medicine. I was an expert at detoxing patients and guiding them through the recovery process from the disease of addiction. But when it came to chronic pain, I felt horribly inadequate. Loretta was not an isolated case. A huge percentage of the patients I was treating for opioid addiction, perhaps as many as 50%, were also experiencing chronic pain. In fact, many had started using opioid drugs because they were in pain, not because they wanted to get high. What was I going to do with these patients? How was I going to help them? I knew at that moment that if I wanted to successfully care for people who were dependent upon or addicted to opioids, and who are also living with chronic pain, I had to strip myself of those automatic judgments, learn everything I could, and find creative and innovative ways to approach the problem of chronic pain. I was already well equipped with a team of caring, highly skilled professionals adept at helping addicted patients by guiding them into long-term recovery. Adding chronic pain to the treatment plan would require that we rethink our approach and adjust our clinical services. Passed down the line. If you are a person in chronic pain, you will almost certainly know what I'm talking about. You have been passed down the line, and, as the months and years wear on, assuming your doctors stick with you, they are likely to get more and more frustrated with their inability to relieve your pain. You might catch them rolling their eyes or checking their watch as you visit them. Trust me, they are unintentionally, even unconsciously, expressing their frustration and fear at their inability to help you. But of course, that doesn't make you feel any better. As Diana, age 70, says, I've lived with fibromyalgia for 16 years. I know that all doctors are busy, and I have yet to find a doctor who is interested in researching and finding out what is wrong with me. No doctor even wants to hear me say the word pain. That is a forbidden word now. My primary care doctor confessed he is afraid of me and my status as a chronic long-term pain patient. He is sending me to unsuspecting specialists. Having no safe, caring doctor in 16 years has taken its toll on me for sure. Diana's complaints about her doctor disasters and the you again attitude she feels every time she enters a doctor's office highlight a deeper problem. Doctors are indeed busy and often pressured to get patients in and out of the office as quickly as possible. It is rare for doctors to spend the time to research and find out the complexity of what is truly wrong with their patients. By research, I don't necessarily mean spending hours on the internet, or as we once did in the library, but rather spending time with you, the patient, to uncover the multiple dimensions of your physical and emotional pain and really listen to you. Acute pain is generally well managed, and doctors are usually comfortable treating it, because the pain indicates tissue injury that can be treated effectively in most cases, and, best of all, generally resolves within days to a few weeks. A child burns her hand on a hot stove. A woodworker slices off the tip of a finger with a skill saw. You twist your knee skiing. Your appendicitis requires surgery. These are all repairable conditions, and doctors know what to do to treat the wound, reduce pain, and help you heal and move on with your life. Doctors also know that they have a willing and remarkable ally, your innate ability to heal. When an injury occurs, your body springs into action, initiating marvelously complex mechanisms to facilitate healing. But chronic pain, lifelong pain that may ebb and flow depending on a variety of conditions but never wholly disappears, can be overwhelming to doctors. I am certain of one thing, which I have learned in recent years from teaching thousands of physicians about chronic pain and the inherent dangers of using opioid drugs for relief of chronic pain. Doctors get frustrated with their chronic pain patients because they are discouraged and disturbed by their inability to help you. We doctors get angry with you because we are annoyed with ourselves due to our own powerlessness. After many attempts, we may adopt what Diana calls a get-her-out-of-here attitude because you, the chronic pain patient, remind us that we do not have all the answers. With patients stacked up in the waiting room, that sense of powerlessness and exasperation with our inability to do what we are supposed to do, heal the patient, leads to one of two solutions: write a prescription or admit we can't help and refer you to a specialist. These actions relieve us of responsibility and require only a few minutes, whereas taking time to really listen to a patient, witnessing the pain, probing the physical, mental, emotional, and spiritual depths of the problem, may take hours. Emotions drive pain. A few months after Loretta was in treatment at the Las Vegas Recovery Center, LVRC, I attended a conference sponsored by the California Society of Addiction Medicine. One of the full-day workshops was Pain and Addiction, Addressing the Tough Cases. That's where I met Barry Rosen, M.D., and Jody Trafton, Ph.D., two brilliant, sensitive, and extraordinarily talented individuals who have had a profound and lasting impact on my work. From the first time I met Barry, I knew I wanted to be like him. Gentle, self-effacing, and sweet-natured, Barry radiated concern, empathy, and yes, love for his patients. He stood well over 6 feet tall, at least in my memory, with big bushy eyebrows, a receding hairline, and dark brown eyes that conveyed warmth and intelligence. I loved watching him interact with patients. He would sit down next to them, often patting their hands or gently touching their shoulder as if to say, "I'm here, I'm listening. Nothing is more important to me right now than you and this moment." Fear, anger, and hostility seemed to evaporate as they realized that he was not the MDAity they had come to expect, but rather a fellow human being who wanted nothing more than to help them and ease their concerns. Rarely had I seen a doctor interact with a patient in a way that conveyed such depth of caring and human connection. Witnessing these interactions, I understood immediately why patients trusted him, why they loved him. He was so completely different from most of the physicians I had encountered in my life, including me at the time, who seemed always to be pressured by time and thus impatient, curt, and even rude as they delivered their diagnoses and medical advice in a stern and professional tone of voice, often finishing their patients' sentences for them, scribbling barely readable prescriptions, and ending the brief interview by looking at their watch with a weighty expression to indicate time is up. From watching Barry with his patients and working hard to model his unique empathic style, I learned essential lessons that I use every day in my own work with people in chronic pain. From Jody Trafton, who has had an equally profound influence on my life and my work, I learned what goes on inside our brain to drive us to think, behave, and emotionally respond in ways that cause us long-term harm. The basic principle here is that our brain is circuited to take shortcuts, even if the quicker route ends up not being in our best interest in the long run. For example, if you take an opioid medication, you get an immediate hit in your brain that is more instantaneous and powerful than the endorphin high generated by exercising. And exercise can be drudgery, with gains accumulating only with consistent effort and over time. Furthermore, if you're in a lot of pain, exercise may actually make you feel worse temporarily. Exercise is thus the longer route, and, when gauged in terms of instant relief, not necessarily the most scenic pathway. It makes sense that a brain that has become accustomed to the immediate reward and relief of opioids would choose that pathway. In contrast to the no pain, no gain rule of exercise, opioids offer the alternate route of less pain, less gain. Barely 5 feet tall, when she was 7 or 8 months pregnant, I remember fearing she would topple over. Jody is brilliant, most evident in her descriptions of work in the research lab, where she has studied brain circuits and neurotransmitters involved in addiction and the behavioral consequences of neuroplastic changes, and on the lecture circuit, where she summarizes this elegant research for physicians like me. Although much of the information she discusses in her talks is hard to follow, I've been able to latch on to key pieces and a deepening understanding of the neurological underpinnings of habit formation and willpower. Jody also describes how addictive drugs pharmacologically hijack the brain's reward system, causing dopamine neurons to fire vigorously, triggering huge rewards that in turn lead to craving for more drugs to experience more rewards. In one of the first of a half-dozen lectures I heard Jody give, she described an experiment that appeared in the Journal of Neuroscience in 2004, in which research subjects received an electric shock. If they pressed a button quickly enough, they were told, they could modify the intensity of the shock so that it was less painful. Subjects reported that pressing the button worked to reduce pain, and scientists confirmed through MRIs that there was less brain activity indicating lower pain levels, and yet the button was not connected to anything. In other words, the subject's expectation that they would have less pain if they quickly pushed the button led to reduced signals in the pain-receiving areas of the midbrain and a decrease in their pain levels. As I listened to Jody lecture, I got really excited because it validated what I witness in my work with patients. If you push the button of believing good things will happen in treatment, knowing that you have some control over your situation, your pain lessens. The better the sense of control you have over your situation, and the more you commit to the work needed to continue to reduce your pain, the greater the benefit of the treatment. The Gift of Pain. Not long after I met Barry and Jody, I picked up a copy of The Gift of Pain by Dr. Paul Brand and Philip Yancey. A compassionate healer and consummate storyteller, Dr. Brand spent much of his life working in India with patients who had Hansen's disease, a bacterial infection more commonly known as leprosy. The prevailing medical theory held that leprosy itself caused grotesque disfigurements in
Sample complete. Ready to continue?